Is there a role for biomarkers in this sort of risk stratification? Patients made it to hospital day discharge. Why not just check a D-dimer?
Well,
if it's totally normal?
So a
Probably won't be, but
yeah,
if it were?
The D-dimer has some predictive value, and Mike has done some nice seminal work on incorporating it into a clinical score. So in and of itself, I don't think it's as useful as being incorporated into a clinical model like IMPROVE. And also, the weight of D-dimer to be predictive of VTE is not, is I would say in the moderate range or intermediate range. So it's not strongly weighted as let's say prior history of VTE. So I think a combination of D-dimer embedded into a clinical risk score is the way to go. And to be honest, I don't think we're quite ready yet for a case finding strategy using screening ultrasonography. You know, we've seen that in especially in surgical patient populations having failed multiple times. So I really think a pound of prevention is worth an ounce of cure at this point. We're really dropping the ball in U.S. health systems is saying, well, now that you've finished your 3 or 4 day length of stay, you're good. And you're discharged home and you don't need anything. I think the next critical step in my view is formalizing what Gary said at admission in the discharge planning process. So we should formalize VT risk assessment, not just at admission, but at discharge. And if patients continue to have high VT risk features, either give them an extra week of anticoagulants, or if they're higher risk than that, maybe they would be candidates for extended prophylaxis. And that's the paradigm shift that we're talking about.
I've just echoed that. It's really a struggle to get systematic assessment of VT risk on admission, but when it's done, it's terrific. The next frontier is actually to get it done at the time of discharge, which very few guidelines call for and very few clinicians actually do. But for some of these patients, the risk score is not going to change, or it may even be worse.
Yeah. All right, so let's say we've made it through discharge, the patient's ready to go. What advice can we give them in terms of lifestyle? Should they exercise, assuming that they can? Should they get up every couple of hours if they're watching TV? I mean, if it's a flight, we say get up every couple of hours. Should they do that at home? Should someone massage their calves? I mean, what exactly are the practical things that we can tell them?
I mean, I think a push for early mobility is something that we can all agree is important. There's a tendency to recommend to patients to take it easy, you know, bed rest, and really we want to do the opposite of that. We want to encourage mobility. We want to encourage return to some semblance of regular daily activity as long as they're capable of doing it. Because we know, as Alex said, immobility is, no matter what analysis, what subset of data you look at, immobility always comes up as very predictive.
Mm-hmm. But specifically, what practical advice we give? So, you know, someone that's had a sternotomy, for example, you might say, you know, take the incentive spirometer home if it's a really early discharge, you know, do it every couple of hours. What do you recommend practically to patients? Of course, some of it's titrated to their ability to ambulate and just how good shape they are or aren't in. But do you have any tips or tricks in terms of what you say?
Staying hydrated. More recently, we've understood that dehydration can increase the risk of VTE twofold in some studies, and so
probably something that's operative on long-distance flights as well, right?
Right,
People
right. That's actually
drinking coffee, alcohol, or not drinking at all.
That's actually what people think may be the key factor in that. So that, and as I mentioned, you know, get moving. Those are two lifestyle things that can be helpful.
Yeah, that's really good stuff.
I mean, what I was going to say, actually, in a quarter of your patients, the answer might be simpler: take your direct oral anticoagulant. So, I mean, the one issue in the post-discharge phase is that we've only had parenteral options. So trying to tell an 80-year-old female patient with rheumatic disease who can barely hold a pen to actually self-inject for the next 2 weeks was an exercise in futility. I think the beauty now and the paradigm shift that we've seen with the trials that we'll be discussing is the fact now that we have oral-only options. We can give these oral agents not just during their hospitalization, but in the post-hospital discharge period. So the business of prophylaxis from the patient point of view becomes a lot easier.
Well, since you've taken us there, let's go there. So with the patients at discharge, we've given that lifestyle advice. What are we going to discharge the patient on? What is the anticoagulant? You've already said you don't favor parenteral anticoagulation at that point, low molecular weight heparin and so forth. What would you all recommend then? What did the data show?
I guess I'll start because everyone's looking at me. I'm not sure why. So I think the one thing that we can tell is, yes, if the patients are at risk, they can always have an option to take low molecular heparin. Very few of these patients do take it. Number two, we do have a prior trial using extended low molecular heparin, the EXCLAIM trial with an enoxaparin 40 milligrams once daily. It was a difficult trial. It was actually a pioneer trial. And I really take my hats off to the investigators to have pioneered the way. A difficult trial to do, difficult with respect to finding the kind of the real at-risk population, but even that trial suggested that patients who were elderly, had immobility, and who were female, it may be these key subgroups. So that pioneered the way, but I think more importantly now we have clearly positive trials from both the APEX trial that Michael headed, as well as the Magellan and Mariner trials that Gary and I headed, and others that show us in key subgroups of these populations, one could give extended prophylaxis with rivaroxaban.
Well, I want to talk about the data from all three trials, but just before leaving low molecular weight heparins here, what about if the patient has a history of cancer? Does that influence anything in terms of low molecular weight heparin versus going to an oral agent as you were otherwise endorsing?
It's an interesting paradigm, isn't it? Because if they're a cancer outpatient, all of a sudden now the data is really pointing to the way that there's a subset of these cancer outpatients that would benefit, right, from either low molecular heparin in the past, but more importantly from a direct oral anticoagulant. But these data really don't apply to the hospitalized cancer patient population. And it's simply because these patients tended to clot but also bleed. So we don't have the right benefit-risk balance, I think, in that particular population.
I'm glad you made that distinction. It's a little bit subtle. And what about aspirin? Any role for aspirin here before we get into oral anticoagulants? Does anyone?
Not for VTE prevention.
Yeah, not really in the medical patient.
So nobody is a taker for aspirin.
A lot of head shaking. That's pretty unanimous. Yeah.